afternoon, good evening, depending on where you are based. My name is Katrien van Laren and I'm your chair today. I head the Open Advanced Health and Science Department at Danone Nutrition Research. And it's a great pleasure to welcome you to the 14th Hydration for Health Conference. Today we are in Central Supélec, a well-known university in Paris-Saclay, which has recently been ranked 14th in the Shanghai Global University Ranking. I really would like to thank the Central Supélec team for welcoming us today. Hydration for Health is a global initiative started 14 years ago. Its goal is to provide a podium for us all to share the latest scientific news in the field of hydration for health, but it's also a way to build a community of people who are involved in research and working to make healthy hydration the new normal. Year after year, the network has grown, gathering all of you, doctors, researchers, students, dietitians, and other healthcare professionals, showing that hydration science is a topic of interesting interest. Do not hesitate during the whole session to like, to tweet about the session, and to share it with others. As you saw earlier in the short video, a series of new publications have been accepted this year, adding new scientific evidence to the importance of hydration for health. Congratulations to all the brilliant authors. So, today, what will we talk about? Well, we start with an introduction keynote lecture from Professor Falwell, independent consultant from the UK, about access to water. As good hydration is vital for everyone, and the fact that water needs to be safe and sustainable in higher, mid, and lower income countries. In the first session, Dr. Burns will show us how exercise can improve nocturia in elderly. Dr. Rangan will speak about hydration in vulnerable people with kidney disease and the challenges they face with increasing water intake to a level that may slow down disease progression. But the good news is that we can change drinking behavior. We know from research that establishing good hydration habits in a young age is the foundation for lifelong hydration habits. We will now share with you an exciting news, award-winning initiative aimed at children called SPLASH, which was developed in collaboration with EASO and EFAT. It will be presented by Mrs. Douglas and Dr. Belgani from the European Federation of Association of Dietitians. After the break, we will welcome the Early Career Research session. This exceptional session gives young researchers the opportunity to share their scientific research. They've worked hard to be ready for today, and I'm very eager to hear their insights. We count on you to vote during this session for your favorite pitch. We'll give you more details on how you vote during the session. So then, the last session will focus on emerging science on the health benefits of drinking water, including research into cardiovascular function. Our presenters are Dr. Watso, Dr. Schill, Dr. Aneuring, and finally, Mr. Will, our ICRA winning from last year, will present new findings about microbiota and hydration. And of course, I would like to thank the scientific committee for their great contribution to build this exciting program. Dr. Gandhi, Professor Johnson, Dr. Lukito, Thank you for your time, your passion, for bringing hydration science alive for all of us. Now, please sit back, enjoy this year's conference, and don't forget to share your highlights on Twitter and other social media platforms. And now I have the pleasure to welcome on stage Tiffin van Haak, a senior hydration scientist of my team at Danone Nutrition Research. She will moderate the session and the Q&A and start with some practical information of today.
Thank you, Catherine. Welcome, everyone. It's my pleasure to be with you all today and to facilitate the Q&A sessions of this year's conference. Q&A sessions are such an important part of the conference. This is where you have the opportunity to interact with the speakers. So I'd like to share with you a quick overview of how to make the most out of these Q&A sessions. So you can type your questions for the speakers in the question tab that you will find at the bottom right of the screen. There is also a chat where you can interact with all participants, but please keep the question section for questions intended for the speakers. For technical support queries, there is a dedicated line accessible both on WhatsApp and Telegram apps. I also encourage you to ask your questions during the talks. This way, this allows other participants to add votes, and we'll be able to select the questions with the most interest from you, from the audience. And if your question couldn't be addressed during a Q&A, this can happen. The speakers have the opportunity to answer it afterwards in writing in the question section. So do keep an eye on the questions tab. And before we start the program with the keynote lecture, just let me remind you that the first Q&A session will cover both the keynote lecture as well as the talks of the first session on hydration and behavior. So now that we're all set, enjoy this 14th edition of the conference and talk to you later in the first Q&A session.
Dear Hydrationists, welcome. I'm Alex Boitestella, and I will introduce today Professor John Fowell, independent consultant on drinking water and environment in the United Kingdom. In his keynote lecture with the title "Have We Lost Sight of What Safe Water Means?", Professor Fowell will discuss about the importance of providing safe water access worldwide. As hydrationists, we often discuss about the importance of consuming the correct amount of fluids and water to perform better and stay healthier. But we have to provide safe water to permit everybody to obtain these benefits of a safe hydration. So the floor to Professor John Fowell.
Hydration is vital for health and well-being. But it's not just hydration, it's got to be hydration with safe water. And sometimes I think we've lost sight in the West of what safe water means. Not all water sources or drinking water supplies are the same. Sources can vary from surface waters to well-protected groundwaters, and there's a huge variation in the type of supplies, from large, well-run municipal supplies to small, resource-poor rural sources. So available safe water is vital, but in many low and middle-income countries, water is not readily available close to dwellings, and that is defined as within about 30 minutes round trip. So the amount of time that's spent is quite significant. Unfortunately, the burden falls primarily on women and girls. And the issue is girls because this is a major barrier in some areas for girls attending school. So education is limited for them. In addition, household storage is often a site of contamination. So the water is stored in the household, but that is also being contaminated while it's there. In 2020, 1 in 4 people lacked safely managed drinking water around the world. That's actually quite a significant number. And WHO estimates that diarrhea still kills, not just makes sick, kills about 525,000 children under 5 every year. And well over a third of that is directly due to contaminated drinking water and poor hygiene. And of course, diarrhea means that those individuals are becoming dehydrated, not hydrated. But hygiene and drinking water are all part of the same cycle. So when you have pathogen contamination by animal excreta as well. So we have then protected supplies, that's good, and then drinking water treatment is a possibility. And that is another step, another barrier in preventing pathogen contaminated drinking water. It isn't always available. So microbial pathogens, the bacteria, viruses and protozoa, these remain by far the greatest risk in drinking water. These are the biggest hazards. We can count the bodies as a consequence. Will there be new threats? Emerging pathogens? We don't know, but it's probable. Human travel means that pathogens can also travel quickly, as we've seen with coronavirus. And while we don't have a lot of data on pathogens travelling or outbreaks being caused by pathogens, by animal excreta as well. So we have then protected supplies, that's good, and then drinking water treatment is a possibility. And that is another step, another barrier in preventing pathogen contaminated drinking water. It isn't always available. So microbial pathogens, the bacteria, viruses and protozoa, these remain by far the greatest risk in drinking water. These are the biggest hazards. We can count the bodies as a consequence. Will there be new threats? Emerging pathogens? We don't know, but it's probable. Human travel means that pathogens can also travel quickly, as we've seen with coronavirus. And while we don't have a lot of data on pathogens travelling or outbreaks being caused by pathogens travelling quickly, we have seen some cases where cholera has been transferred from one place to another very quickly. An infected individual can excrete many, many organisms, and that's particularly true of the viruses, but it's also true of bacteria and others. The example is norovirus that I've given here, where there are 10 to the 5 to 10 to the 11 particles per stool, and in wastewater, treated wastewater, there can be 10 to the 2 to 10 to the 8 per litre. And the probability is, the infectious dose is quite low. We're talking maybe 10, 20 organisms for an infectious dose. In warmer temperatures, possibly as a result of climate change, that can allow other parasites to survive in distribution systems or in storage systems. And there's a whole range of those which are particularly unpleasant and nasty pathogens. And cholera, as I mentioned before, that's still around. It hasn't gone away. We talked about trying to eliminate cholera, but now it appears that cholera is an opportunist pathogen. It lives in zooplankton and it's not going to go away anytime soon. I don't see how we can actually eradicate it. In Western high-income countries, the perception of risk from drinking water is often about trace quantities of chemicals, which may or may not be there. Things like pharmaceuticals, endocrine disruptors, hormones, personal care products. These come from us. We are the source of these things. And they get into wastewater, and then some will be removed in wastewater treatment. Some will naturally then be further removed in surface waters, and some will be further removed in drinking water treatment. But the impact effectively is that we find in Western developed countries a very small number in drinking water, and they are present at very low concentrations. So there's a danger that we have a misperception about the possible risk. Chemical contaminants differ from pathogens. Pathogens produce disease very quickly and with potentially a single dose. Chemicals are unlikely to cause any adverse effects except following long-term exposure. And there's only a very small number that have been shown to actually cause adverse effects through drinking water, so arsenic and fluoride, nitrate in certain circumstances with bottle-fed infants, lead from materials and plumbing used in buildings and to supply water, possibly chlorination byproducts and manganese, but the evidence is indicative only. And we certainly can't say that the impact it's a causal effect. When we produce standards and guidelines for chemicals, we use significant margins of safety or negligible risk in developing those guideline values and standards. There's a move now for more precaution to be built in Western developed countries, but there are important considerations around that. A small difference in a standard can make a huge practical cost difference, at the same time as delivering little or no benefit to health. Treatment can be very challenging. Monitoring and surveillance can be costly and difficult, and that we need routine and available methods to be able to do it. All this adds cost, and drinking water also needs to be affordable. And in many parts of the world, that is a major issue. Advanced treatment is almost invariably energy hungry, and so it can lead to a much bigger carbon footprint. So on the one hand, we're saying that the water industry needs to reduce its carbon footprint because of climate change, and on the other hand, we're saying, well, actually, we want you to do things that will increase your carbon footprint and contribute to climate change. So in summary, good hydration is vital, but drinking water needs to be safe and affordable. For many in low and middle income countries and those faced with war and drought, this is a really major challenge. Safety means free from microbial pathogens. That's the big one. Sometimes from high levels of natural chemical contaminants such as arsenic or fluoride. Perception can be misleading and can cause us to take decisions that are not sustainable and not sensible. So I think we need to readjust our perception of drinking water required for hydration and think in terms of safety and protection from microbial contaminants. Thank you very much.
It is my pleasure to introduce our next speaker, Dr. Danielle Bruns from the University of Wyoming. Dr. Bruns' research primarily focuses on heart disease and heart failure, but as in so many fields in physiology, this interacts with hydration status, renal physiology, as well as elements of the circadian rhythm. So I'm very excited to hear her talk today on nocturia, older adults and exercise. So please join me in welcoming Dr. Danielle Brums.
Good morning. My name is Nellie Brooms, and I come to you from the University of Wyoming. I'm really pleased to be here in my inaugural year of the Hydration for Health. And I'm excited to tell you about a relatively new project ongoing here at UW, aimed at understanding this really prevalent clinical condition in older adults called nocturia, and whether we can use exercise to rescue some of these clinical outcomes. So nocturia is a condition that largely impacts individuals over the age of 65. In fact, it's been reported that up to 40% of adults over the age of 65 report some type of nocturic episode. And what this means is that individuals, healthy young individuals, produce the largest amount of their urine during the daytime. And as we age, the percentage of our urine production during the daytime shifts to a larger percentage of it occurring overnight. And so what these older adults then suffer from is very poor sleep quality, elevated risk for falls as they wake up to go to the bathroom overnight, really resulting in a low quality of life in these older adults. So a multitude of mechanisms contribute to the development of this disease, undoubtedly including several other age-related conditions such as sleep apnea, heart failure, and diabetes. But the mechanism that our group's particularly interested in is the contribution of circadian rhythm to the development of nocturnal polyuria. So most of you may know that many biological processes are controlled in a circadian manner. And so what this means is that lots of physiological processes occur at certain times of day. So for example, with respect to the story that we're talking about today, in most people, their deepest sleep occurs around 2 a.m. As they begin to rise, their body temperature increases. You see a sharp increase in blood pressure. You get this stop in the secretion of melatonin, which helps you begin to wake up. And then we're then alert throughout the day. And so one of the things with respect to nocturia and water production is that right before bed in healthy younger individuals, there's a large peak in the secretion of arginine vasopressin, or antidiuretic hormone, that helps us maintain that urine overnight. And you can see this really nicely in this graph from some young healthy animals that shows this peak in AVP right as the animals are getting ready to go to bed. And we believe that what happens as animals age is that the circadian regulation of AVP release becomes dysregulated. Now, the way that we answer some of these questions in my lab is using mice as a translational model. And not only do we use mice because of their ease of genetic and pharmacological manipulation, but also because they really represent a good model for age-related conditions, including nocturia. And so what I've shown you over here on the right is simply a graphic of how we can measure some of these things in mice. And so what we can do is take a piece of filter paper and lay it across the bottom of the mouse cage. And we can let that filter paper sit there for about an hour. And what the mouse will do is sporadically urinate around the cage. And that urine is then sensitive to UV light, so we can light it up with UV light. And we can quantify where and how much the animals have urinated. And so this really gives us an idea in the aging model that these mice do in fact also develop nocturia, just like we see in human populations. So nocturia is this very common condition, particularly in aging populations. We can model it in humans. What are some of the ways that we can treat it? So because urination is very often linked to fluid intake, the first thought was that we simply needed to restrict the intake of fluid in older adults, particularly in the evening. And when we first started reading about this, we were really dissatisfied with this suggestion, particularly because we didn't really think that fluid restriction and excess water intake was really what was driving disease in these older adults. And so what we did through the help of some colleagues at the University of Washington, as well as my colleagues here at the University of Wyoming, is we simply did a survey of older adults. So we recruited individuals over the age of 65 who reported no nocturia, moderate, so once or twice a week of waking overnight to urinate, or high, so 3 or more times a week to wake up to go to the bathroom overnight. And we asked them to self-report their fluid intake. And what you can see is that there's really no difference in either the males or the females in terms of how much fluid they intake. And in fact, what we found was that the vast majority of our older adults were not even meeting daily recommended water intake, really suggesting to us that it wasn't the intake portion of this water balance problem that was resulting in this phenotype in our older adults. So if you think about the common therapeutics for nocturia, what you may see multiple times up here in this schematic is the reference to antidiuretic hormone, or desmopressin, or arginine vasopressin. And these are all synonymous names for the same hormone that allows us to retain water rather than excrete it. And the reason why we became really excited about this pathway is because AVP is very potently stimulated by exercise. And what you don't see here is that AVP is also very potently stimulated by the intensity of exercise. So the higher your intensity of exercise, the more AVP you secrete. And in fact, one of the other questions that we asked our older adults in that survey data that I just showed you was how many of them were meeting the recommendations for exercise. So how many of them were achieving more than 150 minutes a week of moderate to vigorous physical activity. And what you can see very clearly is those patients who reported having nocturia were less likely to meet those exercise guidelines compared to individuals who are engaging in that regular activity. So we can also measure or engage animals in exercise. So what I'm just showing you here is a quick video of these mice that engage in exercise overnight. And so we can use this model to really ask the question, what does exercise do to these animals to stimulate the release of AVP and then effort to treat some of these nocturia symptoms? So hopefully what I've convinced you of today is that nocturia is a significant problem in the aging population that occurs as a result of too much urine production occurring overnight compared to in the healthy young individuals where it happens during the daytime. And we have this hypothesis that we can use exercise, particularly chronotimed exercise, which I'll talk about in just a minute, to make these older adults look a little bit more like younger folks. And so we're going to test this hypothesis in a study using a clinical trial in older adults. This is going to be spearheaded by Dr. Evan Johnson here at the University of Wyoming, where we're going to bring older adults into the lab and have them engage in an exercise program either at night before they go to bed or in the morning when they wake up. And we suspect that that pre-bedtime exercise will result in that large release of AVP that will reduce their overnight awakening. And then what we can do side by side, parallel here in our lab, is really aim to understand the mechanisms of this rescue by exercise. So we can use gain and loss of AVP via pharmacological inhibitors. We can see, is the protection coming centrally from the brain and the nuclei that regulate the release of AVP, or is it really happening in the kidney at the level of fluid regulation? So this project is really not achievable without input from Dr. Emily Schmidt here at the University of Wyoming. She's really the circadian expert in our group, and by Dr. Evan Johnson, who's shown his face a lot here at Hydration for Health, and who I'm really grateful for to connecting me for all of you. So thanks again for your attention, and I'm looking forward to connecting.
Thank you very much, Dr. Daniela Bruns, for your great presentation. It is my pleasure to introduce to Dr. Gopala Rangan. He's a senior staff nephrologist at Westmead Hospital and professor in genetic kidney disease at the University of Sydney. He's a clinician scientist leading the Michael Sturm Laboratory for Polycystic Kidney Disease at the Westmead Institute for Medical Research. His translational research focuses on the study of autosomal dominant polycystic kidney disease. He is the principal investigator of the PREVENT AD-PKD multi-center randomized control trial, which determined the efficiency of prescribed water intake on the progression of the autosomal dominant polycystic kidney disease. Today, he will present, does drinking extra water help polycystic kidney disease?
Thank you to the organisers for the kind invitation to talk about the topic of whether drinking extra water helps polycystic kidney disease. Today, I'll summarise the key findings of a randomised controlled trial that was undertaken in Australia between 2015 and 2021 to address this important question. This study has been published late last year in the New England Journal of Medicine. The study was funded by several funding bodies, including Down on Research, National Health and Medical Research Council of Australia. Let me begin this talk by explaining what is polycystic kidney disease. It is a common single gene disorder with a population prevalence of 1 in 1,000. It is the most common genetic cause of kidney failure in adults, and it arises due to mutations in either the PKD1 or the PKD2 gene, which leads to the formation of hundreds and thousands of kidney cysts that grow over many decades. Approximately 50% of affected patients develop severe disease characterized by massively enlarged kidneys, recurrent kidney pain, hypertension, and ultimately kidney failure late in life. Why could drinking extra water help polycystic kidney disease? One of the biggest discoveries over the last 3 decades has been that vasopressin is a growth factor for kidney cysts. Therefore, one hypothesis that has been formulated is whether drinking water to keep hydrated reduces the rate of cyst growth in people with polycystic kidney disease by reducing the release of vasopressin from the posterior pituitary gland. Before we commenced the study, we and others tested this hypothesis in animal models of PKD. In our laboratory, using the LPK rat model, the results were positive, confirming that those animals who drank more water had smaller kidneys than those that did not. On the other hand, Katharina Hock's group from the Mayo Clinic demonstrated that in a hypomorphic model of autosomal dominant polycystic kidney disease, hydration did not alter disease progression. So it was important to do a long-term randomized controlled trial for several reasons. First, to provide certainty and high-quality evidence, as no long-term studies in humans have been done to address this hypothesis. Secondly, drinking water is readily available and is low cost, and therefore if the intervention was successful, it could be a very important implication for people with polycystic kidney disease. Thirdly, to make sure that drinking extra water was safe in this population. And finally, it was a very important question that was asked by consumers, PKD Australia, and multiple other stakeholders. This slide shows the design of the trial. It was a randomized controlled trial with 2 groups, one group allocated to usual water intake and the other group allocated to prescribed water intake. The study duration was 3 years, and the aim was to recruit 180 patients who were aged between 18 to 67 years of age with an estimated glomerular filtration rate of greater than or equal to 30 mils per minute. The primary endpoint was a change in total kidney volume measured by MRI scan. A baseline measurement was performed initially at month 0 and a subsequent one at 18 months and 36 months. This was a multi-centre study in Australia involving 12 sites, and analysis of the primary endpoint was undertaken in a blinded manner at the Mayo Clinic. This slide describes the method of the intervention of prescribed water intake. The amount of extra water prescribed was based on the free water clearance formula to calculate the amount of extra water required to reduce the urine osmolality to below 270 milliosmoles per kilogram. Patients allocated to the prescribed water intake group were reviewed by the research dietitian and coached to reach the nominated fluid target. This was supplemented by telephone coaching, SMS texting. In addition, patients self-monitored their urine-specific gravity using dipsticks at home. The fluid prescription was adjusted at 3 to 6 monthly intervals using repeated measurements of the 24-hour urine osmolality. This slide shows a consort diagram of the trial. A total of 187 participants were randomized in a one-to-one fashion into the two groups. Overall, 85% of patients were retained over the 3 years. Discontinuation reasons were similar in both groups, and the primary endpoint analysis was available in more than 80% of patients. This table shows the baseline demographic variables, which were similar in both groups. The mean age was 43 years, 75% of patients were Caucasian, the body mass index was on average 27, and the eGFR was 78 mils per minute. This slide shows the 24-hour urine osmolality and volume over the 3-year period. On the left-hand panel is the 24-hour urine osmolality results. The blue line indicates the intervention group and the orange line is the control group. As you can see, the 24-hour urine osmolality declined in the intervention group at all time points over the 3-year period, approaching 300 milliosmoles per litre. Similarly, the 24-hour urine volume increased from 2.5 litres at baseline to up to 3 litres in the prescribed water intake group, and this is shown on the right-hand panel. And this was consistent also over the 3-year period. However, there was no difference in the serum copeptin levels between the two groups. Also, the number of patients who had a 24-hour urine osmolality below 300 milliosmoles per kilogram for more than 50% of time points, which we defined as a measure of treatment adherence, was 52.3% in the prescribed water intake group and 17.3% in the ad libitum water intake group. This meant that not all patients in the intervention group were compliant with the intervention all of the time at all time points. This slide shows the primary endpoint and the secondary endpoint of the study. On the left-hand panel is the change in height-corrected total kidney volume over the 3-year period. As you can see, the kidney volume increased over the 3-year period, but there was no difference between the two groups. Similarly, on the right-hand side, the eGFR declined, as you would expect, over the 3-year period, but again, no difference between the two groups. The adverse event of special interest in this trial was the frequency of hyponatremia. Overall, 10 patients experienced hyponatremia. The majority of cases were mild and resolved by the end of the study. Other adverse events, however, were similar between the two groups. In addition, we assessed the tolerability of the intervention, and overall, 9% of patients stated that they could not maintain the intervention lifelong in the prescribed water intake group at month 6, and by 3 years, this increased to 21%. So the key messages of this trial were that, firstly, participants were drinking between 2 to 2.5 litres at the start of the trial. This point is significant because the average fluid intake in the general healthy population in Australia is between 1 and 1.5 litres. Therefore, patients were already informed about the benefits of the trial, either from their nephrologist or from social media prior to the commencement of the trial. Secondly, our study shows that drinking more than 2.5 to 3 litres per day did not alter disease progression or did not consistently reduce serum copeptin over the 3 years. And finally, drinking the extra water was, however, safe. The limitations of the study were that it was an open label study. Patients at target osmolality at baseline were not excluded, and a low water intake group was not included. So the final conclusions from the study are that, firstly, the study does not disprove the hypothesis that maintaining adequate hydration slows the progression of ADPKD. And I say this because the baseline water intake in the study population was higher than the general population in Australia. Secondly, drinking between 2 to 3 litres of water per day was associated with a low risk of adverse events. However, prescribing water intake using intensive pill-centered resources alone as a therapeutic intervention was not sufficient to help all patients increase their water intake, and therefore resulted in no changes in disease progression. I'd like to conclude this talk by thanking all the patients and families who participated in this study. I'd also like to thank Professor Jared Grantham, who developed the study with us and helped us develop the free water clearance formula and the intervention, the Data Safety Monitoring Board, and our funding partners. Thank you.
Thank you, Dr. Rangan, for your fascinating presentation. It's my pleasure to introduce our next speakers, Professor Pauline Douglas and Katerina Bologiani. Professor Pauline Douglas is a registered dietitian with an impressive collection of experiences and held positions. To name a couple, she is currently a senior lecturer and clinical dietetics facilitator at Ulster University and leads on the European Healthy Hydration Awareness Campaign. Katerina Bologiani is also a registered dietitian with strong contributions to the dietitian community through mixed methods research and improvement of pedagogical approaches in dietary education. During Katerina's 10 years of experience with European projects, she collaborated with Pauline as a project officer. Both Pauline and Katerina have a passion for taking scientific evidence and developing tools for dietitians that are practical, achievable, and motivate change. Ultimately, they seek to bridge the patient and research. Their passions and expertise led them to being instrumental in the development of the award-winning Splash tool to educate children and young people about healthy hydration, of which they'll be speaking about today. Please join me in welcoming Professor Pauline Douglas and Katerina Bologiani.
Hello from myself and from Katerina, and we thank you for this great opportunity to tell you about the wonderful initiative Splash. Today, we want to talk through really why we needed that hydration tool, the methodology and its development, and the communication and activation strategies that we put into place. We know what a child eats and drinks plays a really important role in determining their growth and health in later life. And healthy hydration is such an important part of this. For a child, there are significant and rapid changes in their body water content, in their body water balance, in their kidney, their thermoregulatory, and their thirst, both functions and developments. So using that evidence base, we also know that as a child, it's important to have adequate hydration, particularly with reference to physical activity and to their cognitive abilities. And children learn from their parents, from their teachers, and from their peers. So we need to take all of this into consideration. We know, and the evidence is very stark, that children are not meeting their adequate intake of water from fluid. So for children in 4 to 9, only 39% are. And when you get to adolescence, only 25% are meeting their intake. And then when we look more specifically at what that intake actually is, you can actually see that in some countries, the water intake is very low. And also what you'll find is that the amount of fluid coming from a soft beverage is increasingly high. So we need to really take all of that into account as we go forward and really focus on what we need to do for children to get them to have healthy hydration. In an intervention program where people actually were given those educational materials of how important water is, what we could see through that evidence with the low drinkers was that there was a sustained intake of fluid, regardless of the fact that there was no further educational interventions. And when we looked into what that sustainable fluid actually was, it predominantly was coming from water. So water is a drinking habit and it can be learnt. We needed then to focus on what we actually needed to do. So what tool could we have that would inform and would improve health behaviour for our children? This was a collaborative approach taken on board by the Non-Nutrition Research, Hydration for Health, from the European Federation of Associations of Dietitians and the European Association of the Study of Obesity. We wanted to have that clear scope to our target audience. It obviously had to be evidence-based, and we wanted something that was easy to navigate and also very easy to use in practice in the various settings and localities we had. And as researchers, again, important that we could evaluate what we actually had achieved.
So taking over from Pauline, I will shortly present you the steps that were undertaken to develop the tool. So first, the team started by doing a good background search of similar initiatives around the world that they promoted water in children and the school environment. So these initiatives were found in Poland, Mexico, Uruguay, Indonesia, and there is another one from the Centers of Disease Control and Prevention in the US, which aims to increase access to drinking water in schools. Second step was to have a clear scope, as Pauline said, and find the needs of our target audience. So what is SPLAS? SPLAS is a hydration for health initiative for children and their parents, and also the school environment. And its objective is to promote healthy hydration in a fun and creative way. And the team started by doing some focus groups with the end users. So one focus group was with school teachers and after-school workers. One focus group was with children of primary school and their parents. One focus group with children of secondary schools and their parents, and one focus group with older children, 11 to 13 years old. And this is because each different age group has a different narrative angle and a different motive to water intake. And indeed, the focus groups found that children aged 3 to 6 years old, the narrative is to drink water to take care of yourself. The children aged 7 to 10 years old, the narrative is to drink water as part of a fashionable trend, while children aged 11 to 13 years old, the motive is to drink water to feel good about yourself. And as Pauline said, after the focus groups, the three main partners, the Non-Nutrition Research, EASO, and EFAT, did a workshop with experts in the field of hydration in order to discuss the key messages for each age group, the typology of the tool, the tone of the tool, and the icons, and the proper translation of knowledge into practice. And of course, make the communication plan of the SPLAS tool. And then the resources were developed, and the team went back to the focus group and asked the children to engage with the resources and get some feedback. So the focus group with the children aged 3 to 6 years old, they said that they really like the tools. It's a very good start to familiarize with hydration messages. They like the playful approach, and they like the tools that integrate school learning with school outcomes like counting for this age. And they also said that some of the tools, they need an older sibling to be involved when there is reading. The focus group with the 7 to 10 years old, they also said they liked the fun, the dynamic, and the universe around the water. They also said that some of the tools could help them to start develop good drinking habits, and the resources were appropriate for this age group. The focus group with children aged to 13 years old, they said that they liked the graphics again, and they liked particularly when they were playing with their younger siblings. The team also tested with the tools with older children, 15 years old, just to confirm that 13 years old is the latest age for playful tools. And here is an example of the evaluation. So the water game, which looks like a Monopoly, it was a very well received water game. It can be played by the whole family. It has a lot of positive messages on hydration. And we have a testimonial from Mohammed. It is like a moral in a poem. It tells you what to do. So not many changes here. Another game, the water challenge, and the concept is to drink water every time you see one of these images, like a car passing by, or the phone is ringing, or a plane. It was also well received by children and their families, but there was some feedback. For example, some children say, we don't live in an area that there are airplanes. So the team had to consider this and do some changes before the final launch. And after doing these changes, the Splash tool was officially launched in January 2021. It can be very easily accessed via website or mobile app. It includes more than 40 printable materials like games, stickers, infographics, songs, videos, and an app for children aged 11 to 13 years. All materials focus on the positive messages on hydration. They're free, easily accessible, and translated in 4 languages: English, French, Spanish, and Indonesian, to facilitate the communication and accessibility of the tool. And I really recommend you after this session to go online and access the website using this link or the QR code. And before I hand over to Pauline, I would also like to introduce you to Aquazi, which is the Splashy model.
It was so important that we had that real communication and activation strategy in place. Katerina said about the accessibility, and for the dissemination, we wanted to ensure that we used all social medias that we could. It was very easy for us to look at the social media aspect because we had bright coloured emojis. We had colours that engaged with all of the clientele at all levels. It was also important that we then looked at the governmental spread and could we get that into policy. So again, moving on to the next slide, that allowed us to look at, for example, this issue or this aspect in Mexico, and we had then being able to educate other healthcare professionals. Conferences we targeted, healthy hydration has been added to curriculum. We've embedded it into train the trainer programs that we're running. We've embedded it into the training of junior healthy hydration ambassadors. It was vitally important that we had key performance indicators that we then could see where people were using, what they were actually accessing, and what were our wins as well. And obviously it came out that our hydro calculator was the #1 interactive tool that we used. As a team, we also really welcomed the recognition we were given by receiving 2 awards, one that was the Best Creative Health Project and one the Best Health Communication. And so now to all of us and to our call for action. As researchers, as nutrition educators, as parents, as grandparents, as guardians, we all have a role to play in improving the health and the healthy hydration of our children and indeed of our future generations.
Thank you, Pauline. And I would like to add also a call to action as a parent from my family. I don't usually share photos of my 20-month-old son, but he's such a very good example of how drinking habits can be established from a very young age. So you can see we have all these different color smiley cups in the house. And the first task is to just pour some water so all cups have some water in them. The second task is to increase our coordination skills and hold the cups without splitting any water. And of course, the most important task is to drink the water from all cups until they're empty, followed by a round of applause from his parents. And of course, I can't wait for him to become 3 years old and start playing the splash tools together. So we really do hope you enjoyed the presentation, and thank you for your attention. Me and Pauline, we are also available for any questions if you have.
It was also great to see friendly faces from some members of our alumni community that introduced the speaker. Thank you so much for that. Before we kick off our Q&A, I would just like to mention that Dr. Rangan will not be able to join us as it is night time in Australia. And I also have a few information for you. There are more than 300 people connected at the moment. So what a community from so many different countries. So really happy to be here with you and happy to welcome on stage our speakers that are live. And we'll kick off the Q&A with the first question for Professor Fawell. So we'll wait for the question to appear on the screen for Professor Fawell. So how do you think climate change will affect access to safe water, and which consequences can we expect depending on the place we are in the world? Professor Fawell.
Well, it's a very good question. One of the key areas will be actually availability of water. We're already seeing in many parts of the world extended droughts and the resultant impact on stored water and the quality of that stored water as well as the quantity. So that would be the first thing, is actual just availability of water. Already we see a number of cities where there have been major problems. South Africa, Cape Town, were really worried about running out of water altogether. And there are big issues in California and around there because there's such a shortage of water in relation to the number of people that are living there. There's always a bit of a balance, but we're also seeing it in areas where the population's not so great, particularly sub-Saharan Africa, where there are some major problems now with droughts that are extending over long periods of time. The other thing that will be impacted will be there are a number of organisms which can live in distribution and storage. And if we don't manage our distribution and storage properly, then those organisms can grow after treatment and they get into the distribution. So you cannot completely seal a distribution system and storage system. So they will get in there just as Legionella gets into the water systems in buildings, and they can grow and they will increase. The number of times they appear will increase because as the temperature in those distribution system goes up, they can reproduce in large numbers. And some of those are really, really nasty organisms.
Okay, thank you so much, Professor Fawell, for these considerations. This is really important to have this in mind. I will take the second question for Dr. Daniel Bruns. Is there any indication to suggest that a specific type of exercise, for example, pelvic exercise, will be more beneficial for nocturia? So apologies, Dr. Bruns, we can hear you. I will try one more time to connect with you. I think you have to unmute yourself.
Sorry. Yeah.
Fantastic.
Sorry.
Thanks for that. Welcome.
Sorry about that, guys. So pelvic floor exercise currently is recommended for patients with nocturia. Unfortunately, it does not appear to be all that successful. Our hypothesis, based on what we're experts in and what we've read in the literature, is that exercise that causes the largest release of AVP would be the most beneficial to help retain that water overnight. And the data pretty clearly shows that high intensity exercise actually induces the largest release of AVP. And so our clinical trial is going to start with doing a high intensity interval training with our older adults.
Okay, thanks so much for your answer, Dr. Bruns. So the next question will be for Pauline Douglas. Hi, Pauline. We'll see the question in a moment. So Dr. Douglas and Dr. Beloyani, congratulations for this fantastic work. Could this tool, SPLASH, be validated and used in intervention programs?
Hello, sorry, I think there's a little bit of a delay just there on me answering. I think it really can be validated to some extent, but because it very much is that interactivity with children, and there is so much that is there, I personally see it would be very difficult to do some full evaluations and validations of it as a specific tool. Totally guided, Katerina, as well, by what you think on the back of that.
Yeah, hello from me as well. Hope you can hear me.
Yes, we can hear you well.
Thank you. So I totally agree with Pauline. It's not a single tool, it's a library of resources. So the scope is for educational purposes and engagement. So if you're about to use it for interventional studies, I guess you should choose the resource that you need carefully and validate it and pilot it before use it in the intervention study.
Mm-hmm. Good to know, good points to know. Thanks so much. I have a quick follow-up question for you, Dr. Beloyani. SPLASH is available in different languages and in different countries. Did you observe any cultural differences in children during the focus group with regards to hydration habits or how they perceive the tool?
So unfortunately, the focus group was only implemented in one country, France. So we can't really say we observe differences, but since now the project is in the communication phase and there are many translations, so we do hope we're going to do an evaluation and feedback after giving some time people to engage, and we do hope we see some differences from there.
Okay, thanks a lot for your answer, Dr. Beloyani. The next question will be for Professor John Farwell again. What do you think about drinking water networks without chlorination, a practice happening in some Northern European countries? Is it still possible in the context of climate change with increasing temperatures?
What a good question. We've been discussing this at length with a number of my colleagues, and the answer is probably, but it will depend on the way that the system is managed. It will require very, very careful management to make sure that you don't get a buildup of sediment, that you don't get biofilm growing on the side that can actually be a source of food for some of these other organisms that can come in. Will climate change make a big difference? Possibly. I don't think we know that yet, because we haven't seen how big an impact climate change is having on the temperature of the water in the distribution systems in Northern Europe. I know that my colleagues in Northern Europe are well aware of this, and they're looking very carefully at how they can continue to manage those distribution systems to prevent contamination with microorganisms. And I think that this is the key thing. They recognize the problem, they recognize the possibility, and they're showing increased vigilance and making sure that it can work. So I think the chances are that it will be possible, but it will require even more care than it does now.
Thank you so much, Professor Farwell. Thank you for your answer. I think we have time for one last question, and it will be for Dr. Bruns again. Other research showed that exercise correlates with better sleep. Does better sleep correlate with higher AVP? And in the planned randomized control trial, could it be that both the control group and the intervention group will see an improvement in sleep quality?
Yeah, I mean, sleep is absolutely one of the things that we're really interested in. To be honest, I don't know if there's any data correlating AVP with sleep, but we absolutely expect that our intervention group will see better sleep, particularly because they will be waking up fewer times overnight with those nocturia symptoms. It's possible that the control group will as well, but we're really optimistic that the better sleep will correlate with those better health outcomes as well.
Okay, thanks a lot, Dr. Bruns. So we are at the end of the Q&A. We're just on time. Thanks a lot to all our speakers again. I'd just like to remind you that to check the questions tab, as some questions we didn't have to answer, we didn't have time to answer during this Q&A, may be answered by the speakers in writing afterwards. We will now have a well-deserved 10-minute break just before the exciting Early Career Researcher Award session chaired by Dr. Lukito. So with that, I see you later at the next Q&A session.
Right, 10 minutes.
Welcome again, everyone. We are waiting for Dr. Wijaja to connect. We are live. These things can happen. So we'll wait a few seconds more, otherwise we'll start the ECRA session because we are waiting for this session. So I'm looking at the H4H team here, and we're waiting for a signal. There is so much suspense here, so we'll have to move on then. So why do we perform the early career researcher award session? We do it to encourage and enable early career hydrationists, to enhance the conference with new research, also to diversify and expand the hydration for health community. And this way we also facilitate an alumni association. So the finalists are mentored by members of the ECRA Review Committee, Dr. Wijaja Lukito, Professor Evan Johnson, Dr. Joan Gandhi. We received so many high-quality entries from all around the world on a wide breadth of different topics. And here you can see on the screen very quickly the 5 candidates for today that we'll be able to hear in a minute. They will pitch their research in a few seconds. And you will be able to vote for the pitch, and you will have all the information available in a few seconds in a video.
Hi, I'm Stefanishi from the Universitat Rovira i Virgili in Spain. Globally, 55 million people have been diagnosed with dementia, and this number continues to rise. Dietary intake is a modifiable risk factor that may help to reduce cognitive decline, and evidence to date has been summarized in the Lancet Neurology. Yet, what is missing? Water, and the World Health Organization currently does not provide recommendations related to water intake or hydration status in their cognition guidelines. This may be because most of what is currently known is from acute studies. For example, as shown in these MRI images, water and adequate hydration were acutely shown to physiologically affect brain structure and function. Short-term studies have further suggested a role for water intake and hydration status in the production of neurotransmitters, blood circulation, transport of micronutrients and oxygen to the brain, and overall brain cell health, which could impact risk of cognitive decline in the long term. Still, there are gaps in our long-term knowledge due to limited research in free-living older adults and lack of evidence from studies examining the relationship of water and hydration with cognition over a multi-year period. Thus, a prospective cohort study within the PREDIMED Plus framework was conducted to investigate the relationship between hydration status, water intake, and 2-year changes in cognitive performance. As shown by the timeline and the map on the right, this study involved over 1,000 adults aged 55 to 75 years from 10 centers across Spain. At baseline, serum samples were collected from which hydration status was determined using calculated serum osmolarity, with lower values representing a more hydrated status. Also at baseline, water and fluid intake was assessed based on data from questionnaires. At both baseline and 2 years, a battery of neuropsychological tests was evaluated, and the main outcome, change in global cognitive function, was determined as a composite score summarizing individual participant results from all tests. Multivariable linear regression models adjusting for possible covariates were fitted to assess associations between baseline hydration and fluid intake with 2-year changes in cognitive performance. Findings showed that over 70% of participants met fluid intake recommendations based on questionnaire responses, as shown by the top bar graph. Yet this was not reflected by the serum osmolarity values, as shown by the bottom bar graph, which indicated over 50% of participants were physiologically dehydrated. The summary figure on the right shows no significant associations with water intake. However, when the physiologically objective marker for hydration status was considered continuously, dehydration was associated with a greater decline in global cognitive function over the 2-year period. Given these findings, it may be important to assess serum osmolarity and adjust fluid intake accordingly in healthcare practices to ensure older free-living adults remain hydrated and able to maintain cognitive health. In future, with more research and robust evidence, it may be appropriate to incorporate recommendations for water intake and hydration status in cognitive-related guidelines. Thank you very much.
low fluid intake induces an increase in the fluid regulatory hormone arginine vasopressin, which promotes greater water reabsorption in the kidneys and more concentrated urine production. However, changes in the major female sex hormones, estrogen and progesterone, may influence this process. Yet females are understudied due to difficulties in controlling for these hormonal fluctuations during a typical study design. Specifically, increased estrogen during the early follicular phase promotes a lower threshold of osmolality change required to stimulate vasopressin release, while increased progesterone contributes to an increase in aldosterone. However, it's unclear if these shifts in estrogen and progesterone and fluid balance impact fluid consumption behaviors across the menstrual cycle. We sought to answer this question by recruiting 17 naturally cycling females for 3 sets of 3 consecutive days during their estimated early follicular, late follicular, and mid-luteal phases of their menstrual cycle. Participants were measured in the lab for nude body mass, provided blood samples to assess their sex hormone and copeptin concentrations, the surrogate marker for vasopressin, and they recorded their fluid intake on their own using the validated Liquin 7 survey, in addition to collecting 24-hour urine samples during each of these 3-day periods. Our samples seem to meet fluid intake recommendations, with their intake not differing between the phases. However, we found urinary osmolality and urinary specific gravity were elevated during the mid-luteal phase of the cycle, suggesting underhydration during this phase. But what was most interesting was our observed interaction effect between hormones. On the left side, we see the relationship between individual person-centered copeptin levels and urinary osmolality at low progesterone levels in red, moderate levels in green, and high progesterone levels in blue on urinary osmolality. We found that when a female's morning progesterone was elevated compared to their own mean, copeptin had a greater effect on concentrating urine, as evidenced by a steeper increase in urinary osmolality when controlling for fluid intake. On the right side, we see the relationship between copeptin level compared to the group mean at low estrogen levels in red, moderate levels in green, and high levels in blue on urinary osmolality. Between participants, we found the urine concentrating effects of copeptin or vasopressin were more pronounced in those with higher mean estrogen levels compared to their peers, again when controlling for fluid intake. But what does this mean? It seems higher progesterone within participants and higher estrogen between participants in conjunction with elevated copeptin or vasopressin promotes increased urine concentration among females. Thus, these sex hormones should be controlled for when assessing urinary markers of hydration status if females are to be measured across different parts of their menstrual cycle. This could have important implications going forward, where these hormones may determine the adequacy of typical fluid intake recommendations for females. But we should first explore how these hormonal interactions occur in females consuming less fluids and those who are taking oral contraceptives. Thank you.
Hello, I'm Elise Parkinson, a second-year PhD student at the University of East Anglia. Older people are more at risk of low-intake dehydration due to not drinking enough, which is associated with multiple long-term health conditions, increased risk of hospitalisation and mortality. Common signs and symptoms of dehydration do not accurately identify low-intake dehydration for older people, and so it is recommended to use directly measured serum plasma osmolality for this population. We do not yet know how many older people are actually dehydrated, and so I led a team of 7 reviewers to conduct a systematic review and meta-analysis using only robust measures to establish the prevalence of low-intake dehydration for older people. We rigorously followed Cochrane and Joanna Briggs Institute guidance for prevalence studies. We comprehensively searched 6 electronic databases, referenced lists of reviews and papers from key authors, and assessed the eligibility of 97 cohort studies. Studies were eligible if they included at least 5 participants aged 65 and over, and measured dehydration using either directly measured serum plasma osmolality, calculated serum plasma osmolality, and or 24-hour oral fluid intake where there was current and volumetric data recorded. And as you can see from this slide, we included 57 studies from 18 countries. 40 studies were eligible to be included within the meta-analysis. We conducted a quality effects model meta-analysis using MetaExcel and subgrouped by dehydration measure. The prevalence of dehydration ranged from 7% of older people being assessed as dehydrated using calculated serum plasma osmolarity, 54% for directly measured serum plasma osmolarity, and 78% of people did not consume at least 1.5 litres of oral fluids over a 24-hour period. As you can see from this slide, heterogeneity was high for all measures, and although further subgroup analyses were required to explore this, it could be due to variation within participant samples or how the blood was sampled. We then subgrouped by care setting using directly measured serum plasma osmolarity to assess low intake dehydration. As you can see, 26% of older people living in the community were dehydrated, which compares to 69% of older people living in long-term care settings. From this meta-analysis, we have found that more than half of older people are dehydrated. It is important for older people and health professionals to be aware of this risk and for drinking to be encouraged amongst this group to prevent dehydration. Our meta-analysis has shown that the prevalence of low intake dehydration does vary depending on which measure is used. Volker et al. Recommends within the ESPEN guidelines that directly measured serum plasma osmolality should be used to measure low intake dehydration for older people. Within our systematic review, older people were more likely to be dehydrated in long-term care settings. Older people living in these settings are more likely to have more complex needs than those in the community, and so we must now develop our understanding of drinking within long-term care settings and implement appropriate evidence-based interventions within these settings. Thank you.
Hello, my name is Kevin Miller, and thank you for your time today. Previous studies have shown that total water intake is related to dimensions of mood. However, these studies used subjective measures to estimate total water intake or used drinking schedules that did not reflect day-to-day habits. Furthermore, sex differences related to the effect of total water intake on mood have yet to be outlined. The purpose of our study was to investigate differences in mood dimensions across total water intake levels and biological sex by using objective measures to calculate total water intake. This investigation is the first to examine the influence of total water intake on dimensions of mood by using D2O dilution method and metabolic water production to calculate total water intake. We calculated total water intake over the course of 8 days in 100 participants. Each participant consumed 0.05 grams per kilogram of deuterium oxide, or D2O, at baseline in day 7. D2O enrichment was measured on days 1 and 8 to determine total body water turnover. Metabolic water production was calculated from the formula below with the help of validated 7-day food diaries and nutrition software. Total water intake was calculated as the difference of the total body water turnover and metabolic water production. The profile of mood state survey was completed on day 2 of observation. Data were organized by sex and divided into high, moderate, and low total water intake categories. We found no significant differences in any mood dimensions between male total water intake groups. However, as presented in the figure, both absolute and relative to lean body mass, females in the high total water intake group had significantly greater alertness and vigor than moderate and low groups, and significantly lower depression and total mood disturbance than the low groups. Effect sizes were large for each significant difference. The primary mechanism to explain these sex differences remains to be determined, but previous research suggests that they may be related to the difference in response to elevated vasopressin levels between males and females. Due to a lower negative feedback loop, females respond by releasing a greater concentration of stress hormones, which may be related to mood. Future investigations attempting to clarify the sex differences in mood states should collect data during both follicular and luteal menstrual phases, as these phases have shown to influence total body water and vasopressin levels in females. After controlling for macronutrient intake and physical activity, follow-up regression modeling in women identified that the addition of total water intake to the model produced a significant change in the F-score for depression, anxiety, vigor, and total mood disturbance. This shows that total water intake enhances the prediction of mood states in females. Because there are many variables that contribute to mood complexity, total water intake should be considered when attempting to optimize day-to-day mood state in women. In addition, total water intake should be considered for designing future investigations that require measures of mood. Thank you for your time.
Hello, thank you to the ECRA Review Committee. I'm Abby Colburn, and I'll be presenting on tap water consumption and perceptions in U.S. Latinx adults. Latinx adults consistently consume less total water and are more likely to perceive their tap water as unsafe. Existing interventions to improve water intake typically target hydration-related education and improving access to water. This may not be sufficient in Latinx populations where water is not trusted. The purpose of this first phase was to identify predictors of mistrust in Latinx adults. We included 492 Latinx adults 18 to 65 years old residing in Phoenix, Arizona. Participants completed an adapted survey of water issues in Arizona and household water security experience-based scales. All factors shown here were statistically significant predictors of tap water mistrust. While organoleptic characteristics of water are not dependable indicators of health risk, it appears Latinx adults may associate undesirable perceptions, such as unpleasant taste or smell, with a lack of safety. Mistrust may also lead to reliance on costly alternatives to tap water, such as bottled water and water treatment systems. The purpose of Phase 2 was to evaluate the influence of tap water perceptions on water intake measured via online dietary recalls, and hydration status measured via 24-hour urine samples. We had 55 subjects, 26 who trusted their tap water, and 29 who didn't. In this figure, you can see the components of total water intake by tap water perception. Total water intake and water consumed via tap water, sugar-sweetened beverages, other beverages, and food were similar between perceptions. However, those who mistrust tap water consumed significantly more bottled water. In these figures, you can see that there were no differences in the percentage of euhydrated individuals or subjects meeting the U.S. total water intake guidelines. In conclusion, Latinx mistrust in tap water is very common and related to organoleptic perceptions. This is the highest prevalence of mistrust that has been observed to date. While tap water safety perceptions were not related to overall water intake or hydration status, we confirmed that Latinx adults who mistrust tap water consume 2 times more bottled water. Minority and low-income communities are at a greater risk of water insecurity, and it's clear there is concern amongst the present sample. Mistrust may cause adults to seek alternatives to tap water, such as bottled water, despite increased economic burden that causes households to sacrifice other needs such as food and healthcare. Thank you.
Thank you.
Hello again, Dr. Luquito. Sorry for interrupting. Sorry for interrupting, Dr. Luquito. We had a problem of sound. We would love you to go back to what you were saying in the first words. Would that work for you? Thank you so much about that. Thank you.
Okay, thank you. So before we vote, we need to consider at least a few parameters on the screen. So please consider, did the study address the important, interesting topic, and was the study executed well? Are the results meaningful? And the conclusions justified? And how well did the candidate communicate? So using these parameters, please now vote, and please prepare your smartphone and scan the QR code on the screen. Let's start now. Next slide, please. Okay, now let's see who will be the winner. Okay, now the winner is Stephanie Nishi. So may I invite Stephanie to come on stage, please?
Hi.
Hi, Stephanie. How are you? Congratulations.
Good. Thank you. There are so many interesting presentations. I'm so honored to be chosen.
Okay, now please, perhaps, you know, the audience would like to know, and especially the young researchers, about your experience, you know, participating in this ICRA. Could you just explain briefly?
Sure. Well, it's been such a great experience, especially getting to hear feedback from the scientific committee as we go through this process and to learn from them and their experiences as well. I had a mentor throughout this, Dr. Travis Anderson, who participated in this competition in a previous year, and he was fantastic in providing insights and suggestions as well. And then I also have to give a big shout out to my team here who listened to me practice and were a big part. So Dr. Jordi Salas Salvador, and especially Dr. Indira Paz-Granal and Carlos Gomez Martinez, who are very integral to helping me with this project and working together on this.
Okay, so once again, congratulations, Stephanie, and all the best for your, career in
Thank you very
hydration
much.
for health. Okay, thank you.
Thank you.
Well, once again, I would like to thank the audience for your active participation, and thanks to the finalists and also the other researchers who have submitted the abstracts to the ICRA 2022. Our next session is now hydration and health, when water drinking matters for short and long-term outcomes. May I invite the alumni to introduce the next speaker, please? Thank you.
Good afternoon, dear colleagues. Again, big congratulations and thanks to our early career research awardees. And now we're moving on to session number 3, which is dedicated to hydration and health. And here is my pleasure to introduce you our first speaker, Joseph Watso, who is currently a researcher in the Department of Clinical Research in the University of Texas, Southwestern Medical Center, USA. Joe is interested in studying the role of lifestyle habits for optimizing health and cardiovascular disease prevention and management strategies. So here now, Joe is going to present his talk on the role of hydration status in cardiovascular system and blood pressure regulation. Let's get started.
The title of my talk is Hydration Status and Cardiovascular Function. To begin the talk for today, I'd like to define a few terms related to hypohydration. The first of which is euhydration on the far left, which is a state of optimal total body water content. The process by which one loses body water is termed dehydration, and hypohydration is a state of a deficit body water caused either by acute or chronic dehydration. Hypohydration is characterized by low plasma volume and high blood sodium concentrations. These two factors have a variety of effects in the body. For increased blood sodium concentrations, this is sensed in the brain, and in response, there is an increase in the production and secretion of arginine vasopressin, which acts on the kidneys to concentrate urine in order to retain total body water. And this increased water retention can help to increase or restore blood volume. And this in turn will help to maintain blood pressure. Now, reduction in plasma volume could reduce blood pressure. And when this is sensed by the kidney, there's an increased secretion of renin. And this changes the angiotensinogen inactive form of angiotensin 1 to increase in concentration. This is converted through angiotensin converting enzyme in the lungs into angiotensin 2, which has two main effects. The first of which is to increase aldosterone secretion. This increases both sodium and water retention, and that of course contributes to improved blood volume and pressure. And the second action of angiotensin 2 is vasoconstriction, which can be an important player in maintenance of blood pressure. So now let's move on to some of the effects of dehydration. The first of which is exercise performance. Here we have a study detailed by Adams et al. In 2018. And this study included male adults cycling at either a euhydrated or a dehydrated state. And through some interesting approach experimentally, they were able to match for thirst between conditions. Nevertheless, you can see that there is an apparent reduction in cycling power output, as demonstrated on the y-axis, in the dehydrated state compared to the euhydrated state. As for cognition, here's an example from the literature of a dehydrated group of individuals having a greater error rate during a sustained attention test. And as for mood, here you can see in a group of female adults that dehydration was associated with a higher total mood disturbance, as demonstrated on the panel on the far right. So for the rest of the talk today, I'd like to switch the attention to cardiovascular disease and low water intake. And the first question might be, why do we care about cardiovascular disease? And I hope it's pretty apparent from the graph on the left side of the screen that plots the number of deaths by cause in the world, pulled data from 2019. And you can see that the gray bar across the top of this figure clearly demonstrates that cardiovascular diseases are the leading cause of death in the world, and almost extend the following 4 causes of death combined. And as far as the linkage to low chronic water intake, there's some evidence in the literature that the age-adjusted cardiovascular disease mortality risk for adults drinking at least 5 servings versus 0 to 2 daily servings of water per day is significantly reduced. So here I have the index groups in blue and the euhydrated columns for females and male adults. And you can see compared to those index groups, those who are chronically hypohydrated with that low water intake have a much higher age-adjusted cardiovascular disease mortality risk. Now, there's a few potential reasons why this could be, and for the rest of the talk, I'll share some experimental evidence from acute dehydration models. The first of which is this study in patients with type 2 diabetes. And what they had participants do was an oral glucose tolerance test after being euhydrated or hypohydrated. And you can see on the left panel, serum glucose concentrations were higher overall throughout this oral glucose tolerance test time in the hypohydrated state compared to the euhydrated state. And on the right, there was no difference in plasma insulin. However, when you put these two values together and calculate the HOMA-IR, which is the homeostatic model assessment of insulin resistance, it's clear that the dehydrated or hypohydrated state was associated with a higher HOMA-IR, indicating a greater insulin resistance. There are other factors at play, one being vascular dysfunction that could be attributed to hypohydration. Here, there's a very simple technique where one can image the brachial artery, for example, and you can see the blue cuff around the forearm. And after that was inflated for 5 minutes and then subsequently released, there's a shear stress mediated vasodilation that occurs. And that's an index of endothelial vascular function. And it's clear from the data on the right that the hypohydrated state was associated with a reduction in this flow mediated dilation, depicted here as a % change from baseline diameter. Next, we know there is some evidence of dehydration impairing heat dissipation. On the bottom left, we have forearm blood flow in a group of young and middle-aged adults. And for the purpose of this talk, we're going to focus on the young adults in the closed black circles. And you can see that during exercise, as you might expect, there's an increase in forearm blood flow. However, when this was repeated in the hypohydrated state, you can see that the peak forearm blood flow is a bit different. And if we draw lines across to compare the two, it's pretty clear that there's lower forearm blood flow in the hypohydrated state. And this is important because the rectal temperature, or an index of internal body temperature, was also elevated, potentially, at least in part, as a result of this reduction in forearm blood flow. And higher core temperatures during exercise could be problematic, potentially if they continue on. Next, we have some evidence of brain blood flow dysregulation. And here, there is a group that performed recordings of internal carotid artery blood flow in a variety of conditions, one being the control condition, one a rehydration after dehydration, And in the closed black bars, after dehydration, they performed exercise. And you can see across exercise intensities on the x-axis that there is a larger reduction in blood flow with the dehydration exercise condition in the black circles. And in order for the brain to maintain oxygen delivery, it had to rely upon a greater oxygen extraction, indicated here from an augmented arterial venous oxygen difference, indicating that the brain sustained its supply of oxygen through extraction when blood flow may not have been sufficient. And the last main article that I'll share with you is related to orthostatic intolerance. And here, the group used progressive lower body negative pressure. And if you're unfamiliar, the picture on the right depicts what that setup looks like. Very simply, individuals are sealed at the waist and their lower body is placed into a vacuum chamber, and that progressively increases. And of course, that pulls blood from the central cavities and upper extremities down to the lower body, which is a validated model of orthostasis or hemorrhage for that matter. Nonetheless, the key finding is that the cumulative stress index, which is a component of both the time and intensity of that suction sustained, was greater in the hydrated condition compared to the isothermic dehydrated or time-matched dehydrated conditions, indicating that dehydration is associated with lower orthostatic tolerance. And some of the work that I performed with Dr. Bill Farquhar at the University of Delaware, we sought to understand if mild forms of hypohydration could affect blood pressure regulation. And on the top left, you can see I've pulled in that original mechanism chart and simplified it a bit. And our working rationale for this and the series of studies we performed was that blood sodium concentrations, when they increase, are sensed in regions of the brain that lack a complete blood-brain barrier. And those signals can result in a cascade that could potentially influence sympathetic and blood pressure regulation at rest and during various stressors, as suggested from animal models. However, when we performed such studies in healthy young adults, we found that short-term water deprivation does not increase blood pressure variability or impair neurovascular function. Likewise, as far as reflexes or reactivity, we also found that water deprivation did not augment sympathetic or pressor responses to either sciatic afferent nerve stimulation in rats or to static exercise in humans. So as a summary of what I've shared with you today, we demonstrated that acute mild hypohydration can reduce exercise performance, cognitive function, mood, increase fatigue, as well as decrease glucose regulation, blood vessel function, thermoregulation, cerebral blood flow during sympathoexcitation, and finally, orthostatic tolerance. Now, the extent to which that some of these acute changes may be related to chronic inadequate water consumption and potential increased risk of cardiovascular disease in the long term is not completely clear. So future work is definitely necessary in this area to figure out these potential mechanisms and interplay. And in closing, I'll leave you with a reference to an article that Dr. Farquhar and I wrote in 2019, which has a great review of the literature in this field. Thank you.
Thank you very much, Dr. Watso, for your presentation on hydration status and cardiovascular function. Next, we have Dr. Fredrika Schill from the Department of Clinical Sciences, Lund University in Malmö, Sweden. Dr. Schill is a resident medical doctor in cardiology at Skånes University Hospital. Her research focuses on the links between the vasopressin system and cardiovascular disease. She recently investigated the elevated risk of heart failure with increasing levels of vasopressin, as well as its association with coronary atherosclerosis. Ladies and gentlemen, Dr. Shield.
Hi, my name is Fredrika Schill. I'm an MD, a resident in cardiology, and a PhD student at Lund University in Sweden. And today I'm going to tell you about why the vasopressin system is important in cardiovascular disease. Vasopressin is a hormone released by the posterior pituitary gland in the brain. Triggers of release are primarily loss of blood volume, such as dehydration or hemorrhage. Hypernatremia and stress are other triggers. And vasopressin is challenging to measure in plasma since the half-life is short. It is bound to platelets and affected by storage time of the sample. So you can both over and underestimate the plasma level. So as a surrogate, you can measure copeptin, which is the C-terminal part of the prohormone of vasopressin. It's much more stable in plasma and it corresponds well to levels of vasopressin. The best known effects of vasopressin is through its receptor, the V2 receptor in the kidney that you may have heard of, which increases water reabsorption in the kidney as a counter effect against dehydration or hemorrhage or the loss of blood volume that I talked about earlier. But there are two other vasopressin receptors, the V1A and the V1B, and they are vastly distributed throughout the body tissues and organs. And as an example, in the smooth muscle cells of arteries, vasopressin causes vasoconstriction. It's involved in hemostasis through activation or stimulation of von Willebrand factor, and it's also found in the heart. It's interesting that vasopressin receptors have been shown to promote both hypertrophy and fibrosis in myocytes of the heart. And that made me interested about how the vasopressin system can be linked also to cardiovascular disease and heart diseases. And previous studies have also shown that increased vasopressin or copeptin is linked to several cardiometabolic diseases. High copeptin levels increases the risk of diabetes mellitus and diabetic heart disease, coronary artery disease and cardiovascular mortality, chronic kidney disease, etc. We also know that the vasopressin system is activated in heart failure, that vasopressin levels increases in established heart failure, and that elevated copeptin levels can also predict a worse outcome in heart failure. So that was things that were known before, but what I didn't know from before starting this project was whether vasopressin, when in the course of heart failure development, vasopressin is increased. Can vasopressin even be a risk factor or be elevated before heart failure develops, or is it just a marker of established disease? So that was the aim of this paper that was published last year. In this study, we analyzed over 5,000 participants in a large cohort called the Malmö Preventive Project, where middle-aged women and men in Sweden participated. And we analyzed copeptin from frozen plasma that was sampled between 2002 and 2006. And then during a median follow-up time of 11 years, after that, we looked into who had gotten the diagnosis of heart failure and who had not. And out of these more than 5,000 participants, 251 had a diagnosis of heart failure. And none of these participants, of course, didn't have heart failure from before. So what was interesting was, of course, what were their copeptin levels at baseline before the diagnosis, before these 11 years of follow-up. So this I've tried to illustrate by this picture. So we divided the copeptin levels in quartiles for parts, and this is illustrated by the test tubes with green liquid. So we calculated the hazard ratio by increasing tertile of copeptin, and as you can see, increasing a quartile or the top quartile of copeptin compared with the lowest quartile of copeptin had a 63% increased risk of heart failure, the SAD red heart, compared with the lowest levels of copeptin. And in this model, of course, we adjusted for age and sex and cardiovascular risk factors such as hypertension, lipids, BMI, diabetes, and the results were still significant with the significance level at 0.05. The same thing is basically illustrated here in this Kaplan-Meier curve. You see the yellow line. That's the tertile 4 of copeptin, the highest levels of copeptin. And that line is well separated from the other 3 lines. So we concluded with this study that elevated copeptin predicts heart failure development, at least in this population, that is middle-aged Swedes without a prior heart failure diagnosis. So now to another interesting result from our latest paper that was also published last year on the athero and atherosclerosis theme. So we know that both atherosclerosis and arteriosclerosis is the cause of great mortality and morbidity worldwide. As you know, atherosclerosis is the narrowing of arteries, and coronary atherosclerosis is the narrowing of arteries, of the coronary arteries. Arteriosclerosis affects the larger arteries, so the aorta as an example, and it's also called arterial stiffness. So there's different ways to measure atherosclerosis and arteriosclerosis that I'm going to talk about just in a minute. In this study, we investigated again over 5,000 participants in another large cohort called the Swedish Cardiopulmonary Bioimage Study. And we used regression models to associate levels of copeptin with coronary calcium score and carotid femoral pulse wave velocity. So these two are measures of coronary atherosclerosis, that's the coronary calcium score, and arterial stiffness, that's the pulse wave velocity. And those are well-validated ways to evaluate coronary calcium load and arterial stiffness. So here I've tried again to illustrate our results, the odds ratios this time. So we divided the copeptin levels into tertiles, into 3 parts, and we could see that the highest tertile of copeptin was significantly associated both with the high coronary calcium score that we set at 100, as well as high pulse wave velocity that we set at 10 meters per second. And in this model, we also adjusted for sex, age, lipids, diabetes mellitus, smoking, BMI, and as well creatinine and C-reactive peptide. So these results are cross-sectional. We can't draw any conclusions about causality or risk here, but there's still an association that is strong. So it's interesting to think about what could be the mechanisms behind this. So to conclude, the previous results and our results from these 2 studies that I've presented shows that elevated vasopressin or copeptin levels increases the risks for or is associated with several cardiometabolic and cardiovascular diseases, including heart failure. It's also supported by the fact that the recent study also showed that hypernatremia, that is linked to high levels of vasopressin, is a risk factor for heart failure. So other studies support this. So of course we need further research to understand why the vasopressin system seems to be linked with these diseases. There are some studies supporting a causal relationship between increased vasopressin and glucose intolerance and diabetes mellitus. That is very interesting. And of course, the next step, if you can establish a causality link, you wonder, is it possible to treat the high vasopressin levels to decrease the risk of these diseases? And there is, we know that if you drink more water, you suppress the vasopressin release. So if you're well hydrated, you have less vasopressin in the system. So could it be a way to modify cardiovascular risk by decreasing or lowering vasopressin levels by drinking water? That seems to be a very easy way to do it. So there are some studies indicating that a reduction of copeptine levels by increased water intake among the people that have high vasopressin levels and low water intake, that they can reduce plasma glucose by increasing water intake. And those studies are very interesting, and of course further studies on that in that area would be very interesting. However, when it comes to heart failure, of course, an increased water intake can be a risk factor for worsening symptoms. So what we're talking about here is only prevention of disease before you have an established heart failure or any other cardiovascular disease. Just to point that out. And here are some references as well. So by this I say thank you for listening, and if you have any questions, don't hesitate, I'll try to answer them. Thank you.
Furthermore, our preliminary results have shown high.
Thank you, Dr. Schill, for your presentation. We are now moving on to a talk from Dr. Sophia Einhorning, who earned her medical degree from Lund University, where she also earned a PhD in internal medicine. She's currently working as an associate professor in the department. Thank you, Dr. Schill, for your presentation. We are now moving on to a talk from Dr. Sophia Einhorning, who earned her medical degree from Lund University, where she also earned a PhD in internal medicine. She's currently working as an associate professor in the Department of Clinical Sciences at Lund University, and also as a medical doctor in the Department of Internal Medicine at Skåne University in Sweden. Currently, her research focuses on epidemiological and intervention studies, exploring the link between the vasopressin system, glucose regulation, and cardiometabolic disease. During today's presentation, she will be discussing how seasonal variations affect cardiovascular risk and how hydration may play a role. Her talk is entitled, "Why Does Cardiovascular Risk Increase in the Winter and Does Hydration Matter?" Thank you, Dr. Einhorning. We're excited to hear your presentation.
Thank you very much for that presentation. I would also like to thank the Hydration for Health team for the opportunity to give this presentation today. So, copeptin is a reliable surrogate marker of vasopressin in plasma. We previously showed that belonging to the top quartile of copeptin concentration increases the risk of diabetes 3 to 4 times compared to the bottom quartile. Furthermore, belonging to the top quartile doubles the risk of cardiovascular mortality in the population Several genetical and experimental studies point at a causal association between elevated vasopressin levels and increased disease risk. The easiest way of lowering vasopressin in plasma is to drink water. In this study, 31 habitually low drinking individuals drank 1.5 liters of extra water per day, daily for 6 weeks. We observed a highly significant reduction in copeptin and a reduction in urine osmolality after 6 weeks of water treatment, and a significant increase in urine volume. Interestingly, we also found that the water intervention slightly but significantly decreased fasting blood glucose levels in plasma. This study was also a pilot study to a large ongoing randomized control trial. This ongoing hydration to optimize metabolism randomized control trial is a 12-month trial which was designed to determine if there is a causal link between lowering of vasopressin and decreased cardiometabolic risk. It is ongoing since 2018, and individuals with habitually high copeptin and low water intake is included. The intervention arm increases their water intake with 1.5 liters per day during 1 year. The primary outcome measure is difference between groups in change in fasting plasma glucose. We noticed difficulties in finding individuals with high copeptin to be included in the study during the summer months. And this was rather surprising, as one would expect a greater segment of the population to suffer from a negative water balance and thus higher vasopressin concentration in the summer. So I started to investigate the seasonal variation of vasopressin. I combined data from 5 different Malmö cohorts in which copeptin has already been measured. I found a significant seasonal variation in copeptin, with the highest concentration in February to March and the lowest in the end of the summer. In the left panel you can see an unadjusted Cosner model and also the error bars with logarithmized copeptin per month. At right you see adjusted Cosner models, in which plotting of models are based on age, body mass index, sex, physical activity, and cohort. We also found that an increase in copeptin that corresponds to the seasonal variation, which is around 0.7 picomoles per liter, was associated with a 4% increased risk of diabetes mellitus and a 2% increased risk of coronary artery disease. It has already been shown repeatedly in large studies a significant seasonal variation in cardiometabolic risk, with the highest risk during the coldest months. Here you can see elevated systolic blood pressure, increased cardiovascular mortality rate, and higher fasting plasma glucose during the winter months. The underlying mechanisms are not known. Seasonal changes in physical activity, dietary patterns, infections, and hormonal fluctuations has been suggested to contribute. I now hypothesize that elevated vasopressin, for example due to a negative water balance, may partly explain this winter cardiovascular disease phenomenon. Furthermore, our preliminary results have shown higher urine osmolality during winter. So we thus hypothesize that elevated vasopressin levels during winter may be linked to a negative water balance during the colder months. In the next step, I also want to find out which environmental factor with seasonal variation that control the seasonality in copeptin. Preliminary results on the association between copeptin and apparent temperature suggest that change in temperature affects vasopressin secretion with a J-shaped relationship, meaning that both low and high temperatures may be associated with higher vasopressin. A large study from Korea previously found the same pattern for other measures of hydration, but they didn't measure copeptin. This J-shaped model also provides an explanation to the incongruent results between our findings of high vasopressin during winter and previous smaller studies from Austria and Japan showing elevated vasopressin in the warm season. So the seasonal variation of copeptin is higher than the seasonal variation seen in cardiovascular risk factors such as blood pressure, lipids, or glucose. The magnitude of the seasonal variation in vasopressin is also large enough to correspond to relevant risk increases of incident diabetes and coronary artery disease on the population level. The seasonal variation of copeptin mirrors the so-called winter cardiovascular disease phenomenon. That is the known variation in cardiovascular disease risk over the year. And we now hypothesize that increased water intake might reduce this winter peak of cardiometabolic disease. Thank you all for listening.
Hi everyone, I hope you're all well. First of all, I would like to say a massive thank you to Dr. Sophia Inherning for the talk on why cardiovascular risk increases in the winter and if hydration plays a role in this. I'm now delighted to be able to introduce to you all the next speaker, Nate Willis. Nate is a PhD student at the University of Illinois at Urbana-Champaign and is advised by Dr. Naman Khan. Nate was the winner of the Early Career Researcher Award at last year's conference for his talk where he presented novel data on the relationship between copeptin and gut barrier function. This year, Nate's talk is going to delve deeper into the relationship between hydration and the gut microbiome. Really looking forward to your talk, Nate. Take it away.
Thank you, Loris, for that wonderful introduction. As you mentioned, today I will be talking about some emerging data in the area of hydration behaviors and physiology with impacts in the gut. Specifically, we've been interested in how hydration behaviors impact the abundance and the function of the gut bacteria, as well as digestive homeostasis. So we here at the Hydration for Health conference are well aware of the importance of healthy hydration behaviors. Improving hydration status has shown to benefit mood, memory, attention, and cardiometabolic health, and most recently has been associated with the relative abundance of gut microbiota. The gut microbiome is comprised of trillions of bacteria, archaea, and fungi that exist in symbiosis with us. Researchers count more bacteria than human cells in our bodies, exemplifying the pervasive potential for health impact. Indeed, the gut microbiota is affected by lifestyle behaviors, including diet and exercise, and is heavily involved in immune and metabolic function. However, the direct connections between these aspects of human health have not been thoroughly explored, though there is evidence to suggest they should be. So how could hydration behaviors impact the gut microbiota? Well, we know that water consumption affects gastrointestinal motility, which is a potent modulator of the gut microbiota. Vasopressin receptors are expressed in intestinal epithelial cells, and in vitro work shows that vasopressin both stimulates the secretion of digestive enzymes to slow gastrointestinal motility and modifies osmotic flux in the intestinal cells. Further, work has shown vasopressin promotes intestinal barrier integrity by stimulating colonocyte differentiation. Part of the intestinal barrier is the mucus layer, shown here in blue. Mucin proteins are secreted by these goblet cells in green and bind dietary water to create a semi-permeable matrix, which expands from the epithelium to protect the tissue from the digestive environment. Many bacteria in the gut colonize and metabolize the sugar residues on these proteins, helping to maintain the integrity of this barrier and fuel their own function. Barrier integrity is vital to normal digestive function, and dysbiosis is implicated in many digestive pathologies. So much of this foundational research has been conducted in vitro or in model organisms, so it is still unclear how this may translate to humans. However, these murky waters, so to speak, are starting to clear, as there have been several studies observing these relations in humans over the past few years. So first, we published these findings linking several taxa with hydration markers in a sample of adults from the Illinois area in North America. What you see here are the top 10 taxa differentially abundant based on the median split of these hydration variables. Further, Van Eck et al. Showed that differential abundance of these taxa between high and low drinkers in a subsample of over 3,000 participants in the American Gut Project. Interestingly, both of these cross-sectional reports show some consistency in the taxa sensitive to hydration markers, which is important as we work to develop a research base in this area. Further, in 2020, Nakamura et al. Published these findings from a 12-week water intervention study in older Japanese adults. This is the only longitudinal study I've been able to find. While the microbiota was not their primary outcome, they showed a significant decrease in 3 taxa. Across these 3 studies, we are starting to see some similarities despite the heterogeneity of these subject samples. Specifically, the common taxa between these studies have been associated with improved metabolic health, probiotic effects, and several genera, including Ruminococcus and Faecalibacterium, are comprised of species known to interact with the intestinal mucus layer, which has led us to several research questions. First, if water intake is affecting mucus-associated bacteria, we might expect to see differences in mucolytic or metabolic capacity based on hydration markers. And, as recent clinical findings have been largely limited by the cross-sectional nature of the studies, we are investigating these relationships further through a water intake intervention to infer causal effects of improved hydration status on the microbiota and the luminal digestive environment. To address the question of functional capacity, we utilized the PyCrust tool developed by the Huttenauer group out of Harvard. PyCrust predicts metagenomic and metabolic pathway prevalence from 16S bacterial markers. We were specifically interested in the gene orthologs from the Kyoto Encyclopedia of Genes and Genomes. So this database contains over 8,000 completely sequenced genomes and is designed to be applicable to other organisms that share functionally identical genes, or orthologs. So we conducted these analyses in the sample we published on last year, which is shown here on the right. We wanted to see if there was a difference in mucolytic activity based on copeptin status as we hypothesized. So we pulled the KEGG numbers relevant to mucus metabolism, specifically enzymes that are required to cleave the sugar residues on those mucus proteins. We split our sample by copeptin median and observed a greater relative abundance of several KEGG orthologs in the below median copeptin group. These differences were statistically significant in beta-glucosidase and beta-galactosidases that are known to be expressed by species in the Faecalibacterium, Bacteroides, Ruminococcus genera, among others. And specifically, we saw these genera to be differentially abundant in humans based on hydration status. This further suggests, at least cross-sectionally, that variable water consumption could impact intestinal barrier homeostasis through these mucus layer bacteria interactions. And at the very least, it shows increased metabolic potential in the relatively more hydrated subjects based on copeptin. However, we are still limited by the cross-sectional nature of these findings. As such, we have launched a water intake intervention study to collect pilot data and investigate the causal relationships between hydration and digestive functioning. This is a simple pre-post design with stool samples, 24-hour urine samples, and blood samples being collected both before and at the end of a 3-week water intake intervention. We're targeting metabolically healthy adults with suboptimal hydration status by screening for digestive and metabolic pathologies and collecting an afternoon urine sample prior to enrollment. After baseline testing, we'll then ask participants to drink 2 or 2.5 liters of water per day, depending on sex, which was approximated to help them meet the USDA recommendation for adequate intake of water. So far, 14 subjects have completed the study with a 75% compliance rate, and we are seeing urine concentration reduced by about half across the sample, indicating that this is improving their hydration status. I was hoping to share more data from this study, but COVID continues to slow us down, and we haven't been able to sequence our stool samples yet. That being said, we have analyzed the stool characteristics to see the effects of improved hydration status. We first looked at stool consistency measured by the Bristol stool chart and hypothesized that water intake would reduce the stool consistency. We are seeing mixed results here. This is a self-report measure, so it's perhaps unsurprising to have such variance. We also measured the pH of the samples and are seeing more of a consistent trend. There is a significant decrease in stool pH across the intervention from an average of around 7 to 6.7. We do know that stool pH is associated with dietary quality, a lower pH resulting from vegan or vegetarian diets, which also have more water. This could be a result then of dietary changes, although we found no significant change in macronutrients or in fiber intake between baseline and follow-up appointments. So we're hypothesizing that the increased water consumption over the intervention could be altering the ratio of water to fiber in the stool or in the luminal environment of the intestine, reducing the viscosity and allowing for greater fermentation of the dietary fibers, which could produce some probiotic effects. While these are preliminary findings of ongoing studies, we are excited by the potential that this data holds. From this data, we see that copeptin is associated with the differential abundance of predicted gluco and galactosidase orthologs, suggesting an impact of body water regulation on bacterial metabolism and potentially mucus layer homeostasis. And further, our preliminary intervention data shows that improved hydration status is significantly reducing stool pH, which is consistent with improved dietary quality, may suggest a moderating effect of hydration behaviors on bacterial metabolism, which we will follow up on. As I said, these are preliminary data, but we are expecting to finish data collection by the end of this calendar year. And once we have the stool samples sequenced, we'll be able to follow up these analyses and offer a more complete interpretation of the impacts of hydration behaviors on these aspects of gut function and what this might mean in the larger context of hydration for health. With that, I would like to thank first and foremost Danone for the opportunity to speak today, and thanks to Matthew in particular for coordinating everything. This is such a wonderful conference, and it's been such an exciting opportunity for me to share our work with fellow hydration scientists. Thank you to my graduate advising committee, listed here on the left. I would definitely not be in this position without their support and direction. They've been super valuable to my education so far. Thanks to the Division of Nutritional Sciences at the University of Illinois for funding this intervention study, and thank you to the specific staff members that are helping me with data collection, and to the rest of the members of these two laboratories for supporting the endeavor. There are also some further funding agencies on the right from which some of this work has been supported, and with that, I would love to open this up for discussion and to take some questions. Thank you.
Thank you so much to the 4 speakers of this session for helping us better understand the links between hydration and cardiovascular endpoints and diseases, and as well as for pioneering research on hydration and gut health. Thank you so much to our speakers. The Q&A session is now open. I'm sure you have plenty of questions for our speakers, and I welcome on stage our speakers that are live. I can see you all. Perfect. So we will start with the first question for Dr. Watso, I believe. We'll wait for it to appear on the screen. Ask for a few seconds. Perfect. Dr. Watso, advanced age is the #1 risk factor for cardiovascular disease. We've heard today about the high rates of hypohydration in older adults. Have any of the physiological outcomes you presented today been assessed in older adults? Do they respond the same as younger cohorts?
Yeah, that's a great point. A lot of the data that I shared were focused on younger adults or even middle-aged adults, but older adults, as you point out, are certainly at a higher risk for cardiovascular diseases. I will say that there's certainly been some evidence of reduced performance in the literature related to dehydration, though not nearly as much as the younger adults, which tend to include elite athletes to elicit pretty severe levels of dehydration. I'm not familiar with any data specifically looking at water restriction, for example, and vascular function in older adults. But I will say that during, as part of my dissertation, actually, we did do an aging comparison with young female adults and older female adults. And surprisingly, they responded similarly as far as blood and urine markers of hydration after a water restriction protocol. So that was not as expected. We would have expected that they would have, augmented increases in urinary and blood markers. So I think there's certainly some work to be done in that area. And those findings were surprising to me, and perhaps others can build on that.
Thank you so much, Dr. Watson, for your answer. And for these new bits to appear in the future, there is some new area of research to occur. We'll now move on to the second question, and this question will be waiting for our technical team. Yes, the next question will be for Dr. Frederica Schill. So we have this question, and I will have to read it on another screen, so can you listen to me carefully? Apologies for that. As we know that increasing fluid intake decreases vasopressin concentration in the blood, do you have fluid intake data on biomarkers of hydration in this cohort to check the potential link? Dr. Shea, the question is for you. Were you able to hear the question well? I think you have to unmute yourself. Sorry about that. We can't hear you for now.
You hear me now, right?
Now we can hear you. Perfect.
Yes. So the question was if we had other biomarkers of hydration in the cohorts?
Yeah, as well as fluid intake data, I believe.
Sorry?
As well as fluid intake data, as I believe.
Fluid intake data. No, unfortunately not. That would have been very interesting, but in this cohort, we only had access to co-peptide measurements. So yeah, interesting point, but unfortunately not.
Thanks for the clarification, Dr. Shah. Thank you. Maybe I can follow up with a quick question for you. Oh no, we have another one. Now, okay, I will follow up with one of my questions for you, Dr. Shih, if you don't mind. Given that there is accumulating evidence pointing to elevated vasopressin as a risk factor for cardiovascular diseases, could we imagine that assessing vasopressin or copeptin could be part of the preventive routine check for cardiovascular disease, just like we measure cholesterol, just like we measure blood pressure? Is this something that is going to happen in the clinical practice?
Yeah, that's actually what we're hoping for and what we proposed in the atherosclerosis article. It hasn't been validated for that, so we don't know, but it would be interesting to investigate if copeptin could be used as a marker of atherosclerosis or arteriosclerosis or heart failure for that matter. So it's a very interesting point. And further research has to be done to investigate that, but interesting.
Thank you so much, Dr. Shah. Thank you so much. And now we'll move on to the next question. And the question is for Dr. Sophia Horning. Knowing the mean level of vasopressin and the fluid intakes of the population, what would be the daily recommended fluid intake for this population? Could these results translate into specific recommendations by medical cardiovascular associations during winter? I think you are on mute, Dr. Horning. Sorry about that. We'll see what we can do. Can you try again?
Now, I
say now? Perfect. Thank you so much. Thank you.
So the question was if the levels of copeptin in the population would make me to recommend a certain amount of water intake. Is that correct?
Exactly, for winter time. Exactly, that's correct.
Yes. Well, if I take in account our previous studies, we have shown that the most copeptin levels that are worse, have the worst scenario for being ill in the future is 6.1 picomoles per liter in women and 10.7 picomoles per liter in men and above that. And the reason for me saying that is that because that is the upper quartile of copeptin levels in almost all of the 5 populations that we have measured copeptin on a broad scale in around 5,000 individuals per population. But all of those populations are Malmö-based, that is southern Sweden. I would say that this would mean that most of those individuals are low hydrated as a reason for having those high copeptin levels. And being ill is also another explanation of having high copeptin levels, as Frederica showed us. But in most cases, I would say that it would be in a broader scale more easy to perhaps look at urine osmolality or even urine color to see if you are well hydrated or not.
Okay, yeah, that makes a lot of sense. Thanks a lot, Dr. Horning, for your answer. So the next question will be for Nate Willis. Super interesting results, Nate, in regards to stool consistency and the absence of statistical differences so far. Did you control the results for fibers intake and energy density of the diet in the previous days? Looking forward to seeing the results of the study.
Yeah, that's a great question. So these data that we showed today were unadjusted. But we did do some at least introductory analyses into dietary variables, and we weren't seeing much of a change in macronutrient consumption or in dietary fiber consumption from pre to post. But I think as we finish the study and we build a more comprehensive model to observe these differences, we will absolutely want to include those covariates.
Thanks so much for these insights, Nate. A very quick follow-up question on that. I'm very curious to know, and the audience is curious to know, when we can expect the full results of this research. You mentioned 14 participants already completed the trial, and when would you expect to have the full results shared?
Yeah, definitely. So 14 were complete at the end, or when that was recorded, and we currently have 24 enrolled or complete. So we are very close to our recruitment minimum here and should be wrapping our data collection in the next month or two, analyzing and processing our samples this fall and hopefully getting a paper out next spring.
Great, looking forward to it.
Thank you.
So we are reaching the end of this Q&A session. So thanks a lot again to our speakers that are live with us. Thank you so much for the engaging and enlightening discussions. It's been a great conversation. We're also reaching the end of the conference. So I'd like to thank everybody who tuned in, who listened in, who asked questions. It's been great interactions with you all. And I'd like to congratulate also our ECRA winner, so Stéphanie Nishi. And I will be holding the trophy. We'll see in a second. I'm holding the trophy that you will receive in a couple of days now. So again, it's been a pleasure to be with you all today, and I will now let Catherine give a few closure comments. Thank you all. Bye.
It has been a wonderful 14th session. We learned a lot, and what amazed me is how we still discover new domains in which water plays a key role, like cardiovascular diseases. We already knew that hypohydration reduced mental and physical performance, impact mood in women, and today some evidence suggests it also impairs vascular function and cardiovascular regulation. Or we knew that increasing water intake might reduce a winter peak of cardiometabolic disease. And on hydration and gut microbiota, we found out that insufficient hydration could affect the gut mucolytic bacteria and impair gut barrier function. Can you imagine the field of research for immune function? Nevertheless, although we know all these things about water, it's difficult to make people drink more water, even if it's recommended by a healthcare professional. That's why all our efforts are needed to facilitate water intake. By example, implementing programs like Splash, or the time we spend together to learn about new evidence on water for health, certainly if water is safe and accessible. I would like to warmly thank all of you for joining us today. Whether it was very early in your time zone or late in the day, it is lovely to have this opportunity to share our insights about water's health impact. Thanks to all the people behind this initiative. Of course, the scientific committee to make its health pack known. To my team, my Danone Nutrition Research team, for bringing the event to life, together with our amazing suppliers working behind the scenes. I would also like to thank our amazing young researchers, our future, for their very professional presentations, and to congratulate the winner of this edition. It's a unique conference that brings people from many backgrounds together to discuss hydration. The breadth of H4H can be considered in different ways. Across different disciplines like sports, physiology, kidney disease, psychology, public health, and more. It enables cross-fertilization between specialisms and further research on this topic. Across professions, with researchers in academia, those who combine research and practice, including public health. This helps us to see both the theoretical applications of what is presented, but also how it can be put into practice. And last, but not least, I hope that you have enjoyed today's conference and will go away having learned something new or eager to make a new connection with some of the people in the audience. The H4H journey is not finished. We need to keep evolving to better understand the importance of hydration for health and how it will evolve in the future. Therefore, we are going to look to how to design the future of H4H. And for this, we need your input. In this year's evaluation form that we will send to you tomorrow, we will ask you for your opinion on what we need to tackle in the future and how we should do that. So please, give us your thoughts to help us build further the future of healthy hydration journeys. And again, thank you all. Spread the hydration science. Have an amazing day and really take care. Thank you.